Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is June 12th, 2026, and I'm your skeptical host, Ken Milne. The title of today's podcast is When You Go Your Way and I Go Mine, Surgery or Antibiotics for Acute Appendicitis. And our guest skeptic is Mr. Ross Fisher. Ross is a pediatric surgeon, presentation guru with his amazing site. And if you haven't checked it out yet, P Cubed, that's right, P Cubed. And he's also a longtime friend of the SGEM. Welcome back to the SGEM, Ross.
Ken, I can't believe that we are spending more time together. You are my favorite person.
Oh, you're my favorite person right now too, because we get to hang out and do projects together on our property. You have spraying credentials now.
I am. I'm the water boy.
Water boy, that's right.
Watering the plants in your garden.
And you also picked the song because you are a huge Bob Dylan fan.
I am a big Bob Dylan fan, and I had to think about the various tracks that you offered me, and then I thought, wait a second, Bob Dylan is just the man, Nobel Prize laureate, and I looked up, and I had lots of different choices. Don't Think Twice, It's All Right, didn't want to go with that, and then I came across this one. You go your way and I'll go mine, because I think, sadly, this is what happens when we present people with the evidence, and however skeptical they are and however they review the evidence, what often happens is you go your way and I'll go mine. And there's a certain sadness to that, but that's Bob.
There is a certain sadness, and the song was about a breakup, a relationship breakup. Mm-hmm. And we've had a relationship with appendicitis for, centuries, that if you have appendicitis, it was almost a monosynaptic reflex. We take your appendix out. But the times, they are a-changin'. We'd used that song before, so I couldn't use that song.
The other one would be Don't Think Twice, It's All Right.
Yeah, you could, or you could think twice because you may not have your appendix taken out, as in NOTA, Non-Operative Management of Appendicitis. We are NOTA gonna take out your appendix today, but we may take it out next time, right? So there was lots of possibilities. But I want to just explain to the audience why you are called a Mr. You are a surgeon,
yes.
But surgeons in the UK are not called doctors, my understanding is.
That's right, because we're better than doctors.
I knew that. I knew there was a reason I liked you and why you went into surgery.
Actually, it's the opposite. So a very, very long time ago, even before I was born, when the world was black and white, and before anesthesia was invented, people needed to have surgery done. And basically, surgery was a knife fight between four strong men, someone holding a knife, and the patient. And it was not a pleasant place to be. So the physician stood at the back and told the person with the knife what to do. And that person with the knife was often a barber or a butcher or somebody in the local village who was good with a knife. And whilst that was sort of effective, like a lot of surgery was back then, what some of the physicians recognized was actually they could cut out the middleman and get in there themselves and do it quicker than saying, that bag that you can find under there, I know he's screaming, but just ignore that. Find that thing with a hole in it. No, not that, the other thing. They would just go, hold on, let me do this. And so they stepped over the blood-brain barrier and got into the knife fight. And they were quicker and better than the man with a knife. And their physicianly colleagues looked down on them and said, you are no longer suitable to be called doctor. We will call you Mr. And whilst at the very beginning that was seen as an insult, there were the surgical brotherhood who got on and did the deed and did it better and recognized that actually being part of the knife fight was a better and quicker way for a better outcome for their patient. And they took on that badge of Mr., not doctor, as one of achievement rather than something to be looked down on. So now men and women in surgery in the United Kingdom will revert to their pre-doctor title to say, I am a qualified surgeon, please, my name is Mr. Fisher, not doctor.
Well, Mr. Fisher, it's great to have you here to go through this non-operative paper. You've been on the SGEM before talking about things. And at that point, when we brought up appendicitis before, you had a pet peeve. Now, we all have pet peeves. And of course, one of mine is when a paper has more than one primary outcome, because we know that
there can be only one
primary outcome. But for you, Ross, it's when people say appendectomy. You just go, ugh! It's like, ugh! Nails on a chalkboard. What is wrong with the word appendectomy, my friend?
I think if the appendix is inflamed and gangrenous, you should remove it. And that would be removal of the appendix. That's an appendixectomy. But in North America, you only take out the append and you leave the ix behind. And a good surgeon knows that if you do so, there is an increased risk of recurrent appendicitis in the ix. So I would suggest if the patient has appendicitis, we take out the appendix, not just the append.
So there we go. We got the pedantic stuff aside. Now we need to get into a case.
A 29-year-old healthy man presents to the emergency department, brackets ED, with 18 hours of abdominal pain that began around the umbilicus and migrated, his pain, to the right lower quadrant. He has anorexia, nausea, a temperature of 38.1 degrees Celsius, and focal right lower quadrant tenderness without diffuse peritonitis. His white blood count is 13,500. His CT abdomen shows an 8 millimeter inflamed appendix with periappendiceal fat stranding and no abscess, phlegmon, perforation, mass, or appendicolith. He is hemodynamically stable. He is not immunocompromised. He has no history of inflammatory bowel disease and can return to the ED if this gets worse. And he says, should I have surgery tonight or not?
Should I stay or should I go now? That would be another good song.
Yeah, that's the Buzzcocks.
Yeah, even for the patient, should I stay or should I go now? Or the appendix, should I stay or should I go now?
Now there's a question.
Because he might leave without his appendix. But appendicitis is one of those diagnoses that we really don't want to miss. It's common. It can be very, very sneaky. You know, that classic textbook presentation, which we created for the case of, I'm feeling, pain around my belly button, my umbilicus, and now it's sort of drifting down to the right lower quadrant, and I've got a fever and a what. If only all the patients read the textbook. So, I mean, it would be so much easier. Or if they just came in a sign on their forehead says, it's my appendix. But they don't. They come in saying, I've got abdominal pain, and they may not have a fever. They may not have an elevated white count. They may not have an elevated CRP. They are not textbooks. They are people. And so labs and various scoring systems can help us, but they can't really rule out appendicitis. And in 2026, for adults, imaging with CT is still doing a lot of the heavy lifting for the diagnosis of appendicitis.
So, as surgeons, we're taught that appendicitis is a surgical emergency. Once we diagnose it, we get on and remove the appendix before it ruptures. The new narrative, though, changes that model. It argues, with evidence, that imaging can identify uncomplicated appendicitis and that perforated and non-perforated, complex appendicitis, if you like, may and probably are biologically different entities. So, short delays to surgery in such uncomplicated disease is not increasing the perforation risk. And that's amazing how few surgeons even know that. This review that we're talking about today notes that the American College of Surgeons, and we have to listen to them, has endorsed antibiotics as a safe alternative for selected patients. That's probably capital S for selected and capital P for patients, while continuing to endorse appendectomy, whatever that might be.
And, over my career, over 3 decades, I've really seen the approach to appendicitis change. Because like you said, you used to just, oh, it's an appendix, it's inflamed, call surgeon, go see next patient, because now the surgeon's going to come in and take it out. And then it got to the point where, well, if it's sociably unacceptable hours and it's uncomplicated, you can sit on that overnight. You can load them up with antibiotics and they can take out during daytime hours. We've been following this topic for years, and our interpretation of the literature has evolved as the evidence has changed. If you go back in time, that's time travel, by the way, Ross. We spare no expense. 2015. So this is over 10 years ago. The SGEM emphasized that diagnostic uncertainty and concern that failed antibiotics could increase mortality. So we were skeptical. We were concerned. And then in 2017, the pediatric conclusion was NOTA, non-operative treatment of appendicitis, was not really ready for prime time. But by 2019, we were more open to antibiotics. And the key is, like you said, in select patients and using shared decision-making and acknowledging that non-operative care may be better than we thought, but it may or may not come with a small absolute increase in some complications.
So the clinical question that we have is, in ED patients, such as we present, with apparently image-confirmed acute uncomplicated appendicitis, can initial non-operative management, that's with antibiotics and observation, with appendicectomy reserved for worsening, non-responsive or recurrent symptoms, can that non-operative approach be considered safe and effective as an alternative to urgent appendicectomy?
And this matters because appendicitis, it really is at the crossroads of emergency medicine, our interactions with surgeons, diagnostic imaging department, whether we're giving antibiotics, talking to the patients about what they value, system capacity issue. It all really comes into this. And some patients want the most definitive treatment. Take it out now. Get rid of the thing. And others want to try to avoid surgery. They don't want to go under, and they're concerned and they have anxiety about it. And so really our job isn't to sell them on one option or another. It's really to explain that there's a trade-off and there's a choice to be made for certain cases of appendicitis.
Why not go to the literature? Talan et al. And their seminal paper, Non-Operative Treatment of Appendicitis and Implications for Emergency Department Management, a narrative review, was published in the Annals of Emergency Medicine 2026, and they attempt to address that problem.
And Dave Talan is a friend of the SGEM. He's been on the show before. He does emergency medicine and a lot of research in infectious disease. And so he's been on the show before talking about long-acting antibiotics for various infectious diseases. So David is the one who reached out to me and said, hey, Ken, will you take a look at this paper? Tell us what you think. And I love that, asking for a peer, a colleague to look at your paper, look at your work, and let us know what you think. And so thank you, Dave. I hope you listen to the show and share this with other people. Let's get to the PCOT. What was the population?
So I'm actually very interested because although it's adults, they have also included children with clinically suspected, localized, imaging confirmed, acute, uncomplicated, and I'll keep saying that word in capital letters, appendicitis. And what they did was included trials that had enrolled children as young as 5 and adults up to and over 80 years of age.
Yeah, I've seen appendicitis in people in their 90s, and I'm like, really? Really? What are you doing? Now you're giving up the ghost? Now you're giving up your appendix? But yeah, 90-year-olds coming in with appendicitis, they can be a bit tricky. They had a number of exclusions, and really the major exclusions was if they had diffuse peritonitis, severe symptomatic illness, or sepsis. They excluded pregnant people again. Immunocompromised, I get that, renal failure, inflammatory bowel disease, and a number of other things. We'll list those in the show notes so you can look at those. How about the intervention?
So the intervention was non-operative treatment, in other words, initial antibiotics and observation, with appendicectomy if the patient worsened, or there was failure to improve, or later recurrence. The antibiotic regimens varied, as they would do, but generally parenteral antibiotics followed by oral antibiotics to complete a total therapy of between 7 and 10 days.
And what did they compare it to, Ross?
They compared it to urgent appendectomy with perioperative antibiotics, usually laparoscopic, but that's what most people are doing in the most recent trials.
All right, let's run through the outcomes. What was their primary outcome of interest?
Is the review did not actually define a single primary outcome, which is annoying, really, isn't it? Because it'd be great if we're all on the same page. However, across the major trials that they reviewed, the most important outcome was the 1-year appendectomy or treatment failure rate. So, how many people had appendectomy in the next year or effectively failed treatment for the antibiotic first care? And in the 30-day outcome, what was their health status?
And then they had a number of secondary outcomes. We'll list those in the show notes too. What type of study was this?
So it's narrative of those major comparative trials they got. And it's not a true systematic review or meta-analysis, just narrative.
And you know what? That's cool because, sometimes I get annoyed when I see these studies that are combined in a systematic review and the heterogeneity is so high in them that really they shouldn't be meta-analyzing them and they should be doing a narrative review. This is what we found, this is what we have, but we can't put any numbers on it to quantify it, give it any kind of certainty with digits and decimal points and those types of things. So I like that actually about this paper. David Talan's conclusions, his and the authors, were, quote, non-operative treatment of uncomplicated appendicitis will be increasingly considered as experience and confidence grows among physicians and as awareness grows among patients in this new treatment option. Emergency physicians are being asked about non-operative treatment of uncomplicated appendicitis and have an important role now to inform patients of their treatment options and expected associated outcomes, and an emerging role in expanding access to safe and cost-effective care for patients with appendicitis, including those who can be managed by non-operative treatment of uncomplicated appendicitis as outpatients. Wow, that was a big, long conclusion.
It's not even just one sentence. That's a paragraph.
Yeah, that's a paragraph. All right, well, let's run through the quality checklist for systematic reviews. The first question is, was the clinical question sensible and answerable?
Oh, yes.
All right, and was the search for studies detailed and exhaustive?
No. So the authors identified studies, and they used standard databases and references, but it was not a systematic search. So they explicitly acknowledge, which is good, that this is a less than comprehensive assessment and therefore there is selection bias.
And were the primary studies that they included in this systematic review of high methodologic quality?
So major trials, large, multi-center and randomized, but open label, variable antibiotic protocols, as we would expect, and allowing subjective decisions to operate, which is going to influence the methodological quality.
And the assessment of the studies was reproducible?
Oops, no. Duplicate data, formal risk of bias process, kappa, Prisma diagram, and no reproducible data abstraction is reported.
Yeah, and we've got to be careful not coming down on them too hard here because it was not a systematic review and meta-analysis. So some of those things would only apply if you were putting the studies together to meta-analyze them. Were the outcomes, do you think they're clinically relevant?
Oh, yes, absolutely. This is happening in every ED across the world right now. Appendectomy, complications, pain, disability, recurrence, ED discharge, patient-centered health status matter to patients. Of course it is.
All right. And, the sixth question was about low statistical heterogeneity for the primary outcome. But because they're not meta-analyzing this, it really doesn't apply to this publication. So we'll go to number 7. Was the treatment effect large enough and precise enough to be clinically significant?
No. Antibiotics avoided surgery in many patients, and so that reduces disability. But 1/3 of the patients who avoided surgery at the first instance had appendectomy by the end of the next year. So the precision depends on the individual trial estimates and what the patient priorities are. And that variability affects how clinically significant we can perceive this to be.
Yeah, so we're really unsure of how large and precise this therapy is.
Yes.
Do you have any idea who funded this review?
I don't think anyone's funded any part of this. The author states no funding was received for this work. You bet your life there isn't. Half of
It's
the research
spoken
is
like somebody who's done research.
so
Did the authors declare any conflicts of interest, though?
no conflicts of interest have been declared. And in this situation, I don't think there are conflicts of interest, apart from the fact surgeons like to operate. So actually, when you take that into account, no, I think that's pretty good.
All right, so let's talk about the results. The review focused on 4 major comparative trials. There was the APPAC, the CODA, the MPSC, and the API. These were all trials. And together they included about 4,000 patients. 2,000 of them were adults and the other half were children. And the review didn't provide a pooled table of, the demographics, like, what were the sex, the race, the baseline pain duration, comorbidities, socioeconomic. None of that was available. So we can't really paint a picture other than it was adults and children. So what was the key result?
The key result is in selected patients. That needs almost to be like in Winnie the Pooh, capital S, capital P for selected patients. With uncomplicated appendicitis, antibiotics worked initially in about 90%. Woohoo! And reduced pain disability for them. But 1/3 of patients underwent appendectomy within 1 year, with a higher risk of that happening if patients had an appendicolith. That is a piece of concrete in your appendix, which has probably been poo, which has got turned to concrete.
So not literal concrete, but it looks like this white, hard, calcified piece of poop stuck in your appendix.
Blocks your appendix and is generally a bad thing. And if it gets out of your appendix because it's perforated, it's very bad. So actually, that's a reasonable thing to differentiate. If there's an appendicolith, a piece of poo in your appendix that is calcified, that's a thing that means you're going to end up with a higher risk of having an appendix taken out.
I just have to be very careful, Ross, because I have a brother-in-law and sister-in-law who are engineers in concrete. Not that they listen to this, but they might take offense if I say that there was concrete in the appendix somewhere. It's just a calcified piece of hard poop, right?
It is just, but it makes a big difference. Lith means stone, so it's a stone in your appendix, which a stone anywhere in the human body is not a good thing. Having it in your appendix, not a good thing.
So like a gallstone, a kidney stone, an appendix stone, a
Exactly.
salivary gland stone. You do not want to get stoned.
Everybody wants to get stoned, but that...
Oh, easy there. I don't want to lose my iTunes rating. All right. So what was the primary outcome?
APAC reported 1-year appendectomy rate of 27% in adults treated with antibiotics.
And then if you switch and look at one of the other big trials, the CODA trial, they found antibiotics were non-inferior to appendectomy for 30-day quality of life score, health status. But when they looked at the 1-year rate of taking out the appendix, it was about 36% without appendicolith, but over half, 52%, if they did have appendicolith.
Okay, so the MPSC, however, reported a 1-year appendectomy rate of about 33% in children.
And then finally, the fourth big trial that they looked at was the APPY, APPY. Most people like appies, like I think in Australia, that's what they call appetizers. Let's do the appies. But it means something different to surgeons.
Yes, I have never done
You were
an
happy.
appendectomy in my life. That's even worse than an appendicectomy or an appendectomy. You're only taking 1/3 of it out there.
Well, speaking of 1/3, they reported about 1/3 or 34% treatment failure with appendectomy in the antibiotic group. And the table in page 3 in the actual review article summarizes all the trial specific results. How about secondary outcomes?
Secondary outcomes. Do we actually care about secondary outcomes? Those generally favored antibiotics for short-term recovery, but not always for those adverse events.
And then we'll list the rest of the secondary outcomes. We'll put them in text, but also in a table form so you can see the key results for the primary outcome and the secondary outcomes.
So I think the last thing is the API study reported no serious adverse events in either group. And that's the worry, isn't it? Because surgeons are always going, if you don't take it out, there's going to be a problem. But there were no serious adverse events in either group, either giving antibiotics or taking the appendix out. But more mild to moderate adverse events with antibiotics, largely GI distress, and we all know what that means, and antibiotics reducing post-discharge pain, medication use, and so-called disability days.
And since you're talking from the surgeon's perspective about being concerned about, if they don't take it out, badness will happen. From a patient's perspective, they're worried about badness due to surgical complications. And it just shows how good, the laparoscopic surgery has become for this medical condition. You guys are really slick about taking these things out using these tiny little scopes and fiber optic cables and those types of things. So it's every surgery has some risk, but this is a very, very well done surgery.
You're just trying to wind me up.
No.
Using the chopsticks and telescopes, there is no evidence, and we can go into this, that using the laparoscope is less risky than doing a small incision in the right iliac fossa and taking the appendix out. But you need to invite me back for a different SGEM to discuss that.
That'll be a whole different podcast.
Different podcast, but it's not about the technique. It's about taking the appendix out.
Well, I had the open procedure when I was a young child, and I'm very happy with my results.
There you go.
All right. So the results, they sound pretty good. Antibiotics avoided pulling out the scalpel for many patients. Patients get back to life faster, and surgeon can still operate if that treatment fails. However, before we start, recommending, hey, everybody go home on antibiotics, I think we need to talk a little nerdy because that's my favorite part of this whole program. So let's talk a little nerdy about this narrative review. And that's nerdy point number 1. It's a narrative review. It's not a systematic review, and that matters. So there's no prisma diagram, no duplicate screening, no formal risk of bias or the ROB assessment. There's no pooled estimate. And that doesn't make this information useless, and we shouldn't really judge it against a prisma systematic review meta-analysis format. It just means we should treat it for what it is, an expert narrative synthesis of the available information.
Okay, and it's important that the audience recognize that this is what you would call open label. The included randomized controlled trials were not masked, and they are vulnerable to what we call performance detection and preference bias. You can't blind antibiotics versus surgery, but when the outcomes include pain, disability, and the decision to operate, lack of blinding, not knowing what's going on, can push things around. And so some failures, as people perceive them, may have been true clinical deterioration. Others may have been the surgeon, patient, or system discomfort with waiting. And that, as a surgeon, I have to say, if I said to some of my colleagues, here is a patient who has had non-operative management and returned with abdominal pain, their response will be, take their appendix out. For some reason, we think the appendix is generally evil and needs to be killed in everyone in whom has ever had abdominal pain. And I personally am not sure that that is reasonable. But in so-called open label studies, that so-called failure may affect the rationale for people having subsequent appendicectomy or appendectomy, whichever is better.
Tomato, tomato. So how about uncomplicated appendicitis? This is the third nerdy point. ED clinicians, we need to exclude abscess, phlegmon, perforations, tumors, diffuse peritonitis, pregnancy, immune compromise, and other high-risk conditions. So yet appendicitis diagnosis itself is imperfect, right? The classic symptoms only occur in about half the patients. Thank you very much. Lab and clinical prediction rules are really insufficient to rule in or out disease. Ultrasound is operator dependent, and the CT can still produce false positives and negative appendectomies. And this means the evidence applies best to carefully selected, look at how many times we're doing that spaced repetition, carefully selected, stable, image confirmed, uncomplicated cases, and does not apply to everybody. Hey, you've got right lower quadrant pain and all appendicitis. It does not apply in general.
Absolutely. The point is that the randomized controlled trials differed by age group, randomization, inclusion of appendicolith, antibiotic regimen, inpatient versus outpatient management, threshold for surgery, primary outcome definitions, and non-inferiority margin. It's not as homogeneous as you would want. A 1-year appendectomy or appendectomy rate is not the same as patient important success. Because if a patient's goal is avoiding an operation today, reducing pain, minimizing time off work, or avoiding recurrence anxiety, it is different than someone who just goes, yeah, take it out, doc, that's all I want. And without a formal meta-analysis, there is no good pooled I-squared, no forest plot, no systematic exploration of heterogeneity. And that is a problem.
Yeah, it's not one size fits all when you've got such different groups being looked at and methods to address the same medical condition, and that same medical condition varies. And we'll emphasize this: whether or not they have appendicolith really matters. The fifth and final point was rare and long-term outcomes. These remain uncertain. Missed appendiceal cancer, it's uncommon, but the review reports cancer in 5 out of 1,000 or so patients qualifying for the antibiotic-treated adults at 2 years, with a median diagnosis at 3 months, and all were stage 1. That's reassuring, but not definitive for older adults of those with atypical imaging. Pediatric outpatient data remains sparse. And cost effectiveness, this really depends heavily on the healthcare system and the assumptions in the model, all those things. So really, I don't feel comfortable commenting on the cost effectiveness of this, because what happens in the US compared to the National Health Service in the UK, to where I am in Canada, to Australia, to the rest of Europe, etc. Cost-effective analysis really depend on the system you're working in and the assumptions in your model. The review is promising for emergency department pathways, though, to be created, but the evidence is not equally mature for children, for patients with appendicolith, older adults, rural sites where I work without surgical backup, or patients with unreliable follow-up. Is that enough nerdiness for you?
That's pretty nerdy. What I would say is that the authors are optimistic about an expanded role for ED and their patients. And I think that's key. It's this idea that surgeons own patients with abdominal pain and orthopedic surgeons own people with bone fractures. It's not the case. ED have a role in this. And the point of this paper is a suggestion that non-operative treatment is a safe alternative for selected patients who have uncomplicated appendicitis. Therefore, ED discharge of that patient is feasible in many adults and pediatric patients, and emergency physicians should be prepared to have this discussion and initiate shared decision-making with their patients about what do they actually want. Are you going to go your way, or am I going to go mine?
Oh, you brought back Bob, didn't you? And we are more cautious due to the strength of the evidence, the diagnostic uncertainty, patient selection, and the possibility of increased perforation or complications with failed non-operative care, and the importance of shared decision-making. And Ross, I've been doing this more and more in my practice, but I still involve in every case of diagnosing appendicitis my surgical colleagues. I am not making the decision, and I am not discharging them home directly from the emergency department without looping in our surgeons at this point in time.
I think that's reasonable because ultimately it's the surgeon who has to carry the end point of that discussion. Antibiotic first, non-operative management is, I believe, and I suggest that this paper supports it, a reasonable option for carefully selected patients, principally adults, with ultrasound confirmed uncomplicated appendicitis. And this paper has used CT for that. It's not for everyone, and we have to be careful that CT itself has a risk of error, but appendectomy is the definitive treatment. Your appendix comes out or the appendicolith, and that's the end of the whole thing associated with the complications involved in it. But it is appropriate that our patients should be involved in this decision-making process, not just saying, as a patronizing approach, you have appendicitis, you're having your appendix taken out. It's not just wishful thinking, and this paper adds to that discussion.
And so how would you resolve the case of the 29-year-old man who presented with this classic textbook presentation of appendicitis?
I would say to the young man, here are the options. We can call the surgeons and they will take your appendix out. And there is another option where we can give you some antibiotics. And if you have no sick leave, if you're comfortable returning to us if this gets worse, you can go home and see how you get on. And if you have whatever appropriate antibiotics there are for your district, because remember, of course, that there is no firm evidence to support one single antibiotic policy, if after a few days you are afebrile, your pain is improved, you're feeding and you're happy and healthy, then no, we don't have to take your appendix out. But if your pain increases, if you have a fever, if you feel worse, or if you feel worried, you come right back here and we'll get in touch with the surgeons. And I can bet your life that they will take your appendix out because they will feel that the appendix is evil and needs to be treated with extreme violence.
Well, I've got here that the case resolution is that we get the CT scan and it shows uncomplicated appendicitis without appendicolith. Surgery is consulted, and after discussing appendectomy versus antibiotics, the patient says, you know what, I really want to avoid surgery today. That's very important to me. He has no paid sick leave, and he's comfortable returning if he's worse. So we give him a dose of IV ceftriaxone in my area, plus metronidazole, analgesia, some antiemetics. And after a few hours, he's afebrile, the pain's improved, he's tolerating oral intake, and he's hemodynamically stable. So we discharge him home on oral antibiotics for a week or 10 days. And then we give him strict written instructions, when to return if worse, and follow up and all that kind of stuff.
Sounds good to me.
So what do you think, how do you think clinicians listening to this should apply this narrative review?
First of all, remembering to be skeptical. Secondly, involving the patients in their discussion. My experience of patients is some are terrified of the appendix bursting, whatever that means, and some are terrified of anesthesia. So offering them an option and being involved in the discussion about what happens to them, I think is a positive way. Highlighting that there's a possibility that they may be treated effectively by antibiotics alone, but that there is a risk in that group that some of them may have to come back. And then saying, what do you think? Do you want to go your way or do you want to go mine?
It's time for the Keener contest, and last week's winner was our good friend, Dr. Stephen Steltz from New Zealand. We are asking about the 3 features that the 2024 International Consensus Report defines DKA, or diabetic ketoacidosis. And Stephen got the correct answer. It was diabetes or hyperglycemia, and they define it as a blood glucose higher than a certain level. ketosis, and metabolic acidosis. So congratulations for another win. Do you have a keener contest for this episode?
I do. I think we've discussed it before, but here's the question. What is an appendicolith? It's not made of concrete.
Yeah, there we go. Yeah, I was just going to throw hint. It's not made of concrete. Now, we have covered this whole idea of appendicitis and non-operative treatment of appendicitis multiple times, and I'll list those previous shows in the show notes. But Ross, thanks for doing this, and I'm going to see you pretty soon.
Can't wait, buddy. All I want to say is, first of all, I'm bringing the whiskey. Secondly, remember, be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.
Talk to everyone next time.